destroyed, the body is usually able to repair or replace the damaged tissue. This is not true when the hard tooth structure has been destroyed. The damage is permanent. Dental caries is initiated by microbial or bacterial activity on the tooth surface. A prerequisite for the development of dental caries is the presence of plaque on the surface of the tooth. The dental plaque is composed of precipitated salivary mucoids and microorganisms. Also present are polysaccharides, mainly produced by streptococcal organisms. These polysaccharides provide a sticky mass which helps the cohesion of the dental plaque as well as its adhesion to the enamel surface. This plaque then provides a very convenient culture medium for bacteria and allows the bacteria and their byproducts to be placed intimately on the tooth surface. Dental plaque is usually located on tooth surfaces that are difficult to clean. Plaque may be present in the crevices on the occlusal surfaces of teeth or at the cervical margins, both which are difficult to clean with a toothbrush. Although there are several theories about the etiology of dental caries, most authorities subscribe to the acidogenic theory. The acidogenic theory of dental caries depends on three factors. First is an adequate supply of carbohydrates or dietary sugars in intimate contact with the tooth surface. The second is the presence of microorganisms which are able to utilize the carbohydrate in the plaque as a metabolite and produce acids. The third is a susceptible tooth. Smaller bacilli and cocci become entrapped in the reticular network of the plaque. Acid-producing streptococci and lactobacilli are particularly numerous. It is known that carbohydrates, which are entrapped within the dental plaque, are acted upon rapidly by acid-producing bacteria. This acid production then leads to the initial decalcification of the enamel, which is the first stage of dental caries. The next subject to be covered is contributing factors in dental caries. The complexity of this problem is underscored by the fact that there is remarkable variation in the caries incidence between different persons of the same age, of the same sex, race, and geographic area, even those who subsist on similar diets under similar living conditions. These contributing factors, then, are probably responsible for the variations in caries incidence. These factors are listed on page 376 and 377 in your textbook. First, the composition and morphologic characteristics of the tooth. Secondly, the physical factors. And third, the composition, quantity, and pH of the saliva and factors in a person's diet. The most important feature which predisposes to the development of caries is the presence of deep, narrow fissures on the occlusal surface of the tooth and occasionally on the buccal and lingual pits. These fissures tend to trap food bacteria and are so tiny that the toothbrush bristles are not able to clean the fissures properly. This has led, in just recent times, to the development of fissure sealants. The sealants, which are discussed on page 424 of your text, are applied as soon as the tooth erupts and tend to prevent bacteria and food debris from becoming impacted at the base of these defects. Another factor in dental caries is tooth position. Teeth which are malaligned or out of position may be difficult to cleanse and therefore favor the accumulation of food and debris, leading to dental caries. The difficulties involved in studying salivary flow and saliva have complicated the problems involved in attempting to determine the role of saliva in dental caries experience. The quantity of saliva, noted in the text on page 381, probably influences caries incidence. It is a well-known clinical fact that patients who have a reduced salivary flow, such as results from radiation therapy, or those patients with xerostomia, have an increased and sometimes rampant caries experience. It was suggested at one time that saliva contained, at least in some people, antibacterial factors. The evidence today is unclear whether such factors do exist in saliva. The diet factor. There is much evidence to indicate that a person's diet plays a major role in the development of dental caries. One item is the physical nature of a person's diet. Persons who eat soft, refined foods which are rich in carbohydrates have a greater caries incidence than persons who consume a diet consisting of raw, unrefined foods containing a great deal of roughage. The vitamin content of a person's diet has been reported to have a significant effect on dental caries incidence. Generally, it has been shown that persons who suffer from a vitamin deficiency during the formative years may be more susceptible to dental caries. This does not apply to all vitamins, but to those vitamins which have an effect on a developing tooth. First of all, vitamin A is necessary for the proper development of ameloblasts, the cells which produce enamel. A vitamin A deficiency, then, could lead to improperly developed enamel. The second vitamin is vitamin D. This vitamin is necessary for the proper calcification process in both teeth and bones. Persons who suffer a vitamin D deficiency during the developmental years may demonstrate enamel hypoplasias or calcification deficiencies in their teeth. Although many studies have been done on other vitamins, the evidence at this time is inconclusive. An important factor in the diet related to dental caries is the fluorine content. Many studies have shown that with an optimum amount of fluoride in either the diet or the drinking water, dental caries is significantly reduced. Fluoride and its relation to dental caries will be considered in more detail in your course in community dentistry. There are a number of systemic factors which have been associated with caries incidence in our society. Heredity seems to be important because the shape of the teeth, particularly the development of occlusal pits and crevices, may be genetically determined. It is difficult to evaluate all factors which are considered to be hereditary, since the environment, eating habits, and cooking habits are generally the same within an individual family. In this country, it has been reported that black children exhibit less dental caries than comparable groups of white children over 10 years of age. In general, however, the evidence that heredity per se plays a definite role in dental caries incidence is somewhat controversial. The clinical aspects of dental caries are very important for the dental auxiliary. Dental auxiliaries may be involved in the detection and identification of carious lesions and also in the restoration of carious lesions after the cavities have been prepared. There are several ways in which dental caries is classified. First, the classification may be according to the location on the individual tooth, such as in a pit or fissure or on a smooth surface. Sometimes, because of the clinical rapidity of the lesions, the process may be classified as acute dental caries or chronic dental caries. Thirdly, caries may also be classified according to whether the lesion is a new one attacking a previously intact surface, such as is shown on the radiograph on page 391 in your textbook. Or caries may be further classified as being secondary or recurrent caries, occurring next to or beneath a faulty restoration, as is illustrated on page 392 in your textbook. This frame illustrates pit or fissure caries demonstrating early decay starting from a deep, narrow pit. Once the carious process has reached the dentino-enamel junction, the process tends to spread laterally. Therefore, only a very narrow opening may appear on the occlusal surface in the area of the pit. However, the enamel may be undermined for a great distance on either side of this pit. Smooth surface caries. This type of caries develops on the interproximal surfaces of teeth or on the buccal and lingual surfaces near the cervical margin, areas that are obviously smooth and have no pits or fissures. These are also the areas that are difficult for the patient to clean unless he makes a vigorous use of dental floss. Since these areas are difficult to clean, retention of carbohydrates and microorganisms on the tooth occurs, and there is the subsequent metabolism by bacteria of these carbohydrates with the production of acid. In the early stages, when you are examining these areas clinically, they appear as a white opacity of the enamel. This is because of the partial decalcification by acid. Smooth surface caries, and in particular cervical caries, clinically almost always presents an open cavity and does not present a narrow point of penetration, which was commonly seen in pit and fissure caries. Here is extensive decay as a result of interproximal caries. Another example of smooth surface caries, and in particular cervical caries, is the figure 7-1 on page 366 in your textbook. Recurrent caries is that type of dental caries which occurs in the immediate vicinity or in contact with a restoration. It is not due to carious dentin, which was incompletely removed prior to insertion of the restoration, but is more likely due to inadequate extension of the cavity preparation, which then allowed debris, bacteria, and carbohydrates to be retained. This then led to the initiation of a new carious process. In other instances, this type of caries may be due to leaky margins around a poorly adapted restoration. The next section deals with the histopathology of dental caries. Some information about the microscopic appearance of dental caries is necessary for the dental auxiliary to understand the basic process. Dental caries occurs in different forms depending on whether it involves the enamel or the dentin. This is probably because of the markedly different structure of enamel and dentin. Since the composition of enamel is more than 90% mineral, the carious process in enamel is basically that of decalcification. The organisms involved in this process are those that produce acids as a result of their metabolization of carbohydrates. Here we see a chalky area of enamel, indicating that it has been partially decalcified. This shows how it looks under the microscope. The soft X-ray illustrated in your text on page 379 demonstrates the loss of mineral in this area. Further examples of this microscopic appearance of enamel caries can be observed on page 398 in your textbook. The process of enamel decalcification does not differ in pits and fissures than it does on the smooth surface. The structural or anatomic features account for the differences we see clinically. Generally, the enamel at the base of pits and fissures is quite thin compared to the enamel on the smooth surface of the tooth. Therefore, the enamel in pits and fissures can be penetrated with greater speed and the dentin reached more promptly. Caries of the dentin. The carious process in the dentin is markedly different from the carious process in enamel for the following reasons. First, the dentin is composed of tubules which run from the dentino-enamel junction to the pulp cavity. These tubules provide pathways for bacteria to advance toward the pulp chamber. Secondly, dentin does not have the same mineral content as does enamel. It has a much higher matrix content, and so the carious process tends not to be one of simple decalcification. Different types of organisms are involved in the destruction of dentin than in enamel. Once the carious process is penetrated through the enamel and reaches the dentino-enamel junction, a lateral spread occurs which involves numerous dental tubules. This lateral spread occurs under both pit and fissure areas and smooth surface areas. If the lateral spread has been considerable, large portions of overlying and apparently uninvolved enamel may fracture away. A large area of carious dentin is observed here. Other examples of the lateral spread of dental caries at the dentino-enamel junction can be observed in the photographs on page 402. Once the carious process has reached the dentin, bacteria begin penetrating down the tubules. These have been termed pioneer bacteria. This demonstrates bacterial penetration within dentinal tubules. The stain is a special stain for bacteria. Acid-producing bacteria are apparently responsible for the initial decalcification of the dentin, which occurs in the carious process. In this respect, it is similar to caries of enamel. However, another mechanism is necessary for the ultimate destruction of the remaining matrix of the dentin. Since this matrix is of a collagen or protein makeup, the destruction most likely occurs by the action of proteolytic enzymes, which are produced by other types of bacteria in the carious process. This accounts for the soft appearance to the carious dentin that all of us have observed and felt clinically. The dentin attempts to protect itself against the invasion of the carious organisms by undergoing certain changes. One of these, noted on page 400, is known as dentinal sclerosis. Dentinal sclerosis is a reaction of the vital dentinal tubules and the vital pulp, which results in a calcification within the dentinal tubules. This tends to seal off the dentinal tubules from further penetration by microorganisms. Another way that the dentin attempts to protect itself from the invasion of microorganisms is by the formation of tertiary or secondary dentin, as is illustrated. Generally, however, these defensive processes are not sufficient to completely retard the advancing carious process. If the process is not intervened by dental procedures, sooner or later progression to the pulp results. This results then in inflammation and eventually death of the pulp itself. Dental radiographs are vital tools in the detection of dental caries, both by the dentist and auxiliaries. It is particularly important for detecting interproximal carious lesions. Various studies have revealed that the radiographs may help in detecting at least 50% more cavities than can be found with a simple mirror and explorer technique. The subject will be covered in more depth in your course in dental radiology.